welcome to Feeding Souls, Protecting Bodies. I'm Rachel Deere with DKB Med. Florida has one of the nation's highest rates of new HIV diagnoses, and Black and Hispanic individuals account for most new diagnoses. Inadequate access to food and unstable housing are barriers to optimal preventive care. This webcast is a recording from a presentation at Sunshine Cathedral in Fort Lauderdale, Florida, in September 2024. It explores the inequities in HIV care and how we as healthcare providers can address them. And now I'll hand it over to our esteemed faculty, Dr. David Sirota, Associate Professor at the University of Miami Miller School of Medicine.
All right, thank you very much. I really appreciate you inviting me to be here, as well as the church, which is beautiful and the nicest place I've ever done a presentation. Much better than our university lecture halls. So first, I will say I don't have any disclosures. I will be referencing the unlabeled or unapproved use of on-demand PrEP, non-occupational PEP, and the use of PrEP to prevent acquisition of HIV via injection drug use. And I'll also mention briefly lenacapavir for PrEP. This activity is supported by an independent medical education grant from Gilead Sciences. All activity content and materials are developed solely by the planning committee members and faculty presenters. Okay, so this is accredited by PACE for AMA, ANCC, and AAPA credit. So we'll start with our learning objectives, which I'll just read to you. Describe disparities in the use of HIV prevention, evaluate benefits and tenets of practicing with cultural humility, define eligibility and contraindications for PrEP, and identify regimens that are suitable for the rapid initiation of antiretroviral therapy. So to start things off, we have some pre-test questions, which we're going to go through. We'll reveal the correct answers at the end of the presentation, so you'll have 2 chances to take these. Hopefully you'll do better after you've heard the presentation. For people in the room, you can use your mobile devices by scanning the QR code that you were given. And for those watching online, you should see a poll pop up on the screen. Okay, so the first question is, which of the following populations has the highest HIV rates and is least likely to receive a PrEP prescription? A, Asian, B, Black, C, Hispanic, D, white. So I'll give a couple of seconds for people to key in their response. Okay, question number 2. Cultural humility is theorized to lead to all of the following except A, greater self-awareness, B, reduced implicit biases, C, increased sensitivity to power dynamics, or D, elimination of all cultural misunderstandings. Okay, question number 3 is coming up in a second. Which of the following is a contraindication to PrEP? A, current injection drug use, B, pregnancy, C, reactive HIV test, D, hepatitis B infection, or E, the use of feminizing hormones. And then our last question is number 4. Which regimen can be offered to people with no previous use of PrEP who are newly diagnosed with HIV, even before the results of baseline laboratory testing are available? A, abacavir, lamivudine, dolutegravir, also known as Triumec. B, bictegravir, tenofovir, emtricitabine, also known as Biktarvy. C, lamivudine, dolutegravir, also known as Dovato. And D, tenofovir, emtricitabine, rilpivirine, also known as Odefsey. Okay. So for people who are here, people who are online and in the local community, we need your help. We want you to sign up if you're willing to be in our referral network. So in a couple of weeks, when we have this health fair here and do free HIV testing, we'd love to have a sort of pool of people we can refer individuals to who test positive or who test negative and are interested in HIV prevention interventions, which we'll talk about today. All right, so I'm going to start the presentation with an overview. First, we're going to go through some epidemiology. So HIV in 2023, which is when we have the most recent data in the United States, overall rates are going down, but the demographics are really important to recognize with our prevention and treatment efforts. So you can see the kind of the breakdown of the new diagnoses of HIV currently. More than half of them are among very young individuals. So people less than 35 years of age make up more than half of new diagnoses. Also, we can see that this is really an epidemic currently of minoritized individuals. So you can see Black and Hispanic individuals make up about 3/4 of new HIV diagnoses. And overall, the general rate of HIV incidence has been declining over time, but those decreases have not been or have been disproportionate. So one positive finding is that the rate of decrease for Black individuals has been the greatest. So that's sort of good in that it's decreasing the disparity between Black and other demographics. You can see, however, the newest increases are among people of Hispanic origin, which has increased 24% over the last couple of years. Think about how are people getting HIV. So about 2/3 is related to men having sex with men. That includes transgender women. About 1/4 is heterosexual contact, and then about 9 or 10% is related to injection drug use. There's a lot of overlap in those, and sometimes people fall into multiple categories, but that's sort of how the data breaks down. And along with that, you can see that based on gender, it's about 80% versus 20%, cisgender men versus cisgender women. So another way to kind of think about this data is to look at an individual demographic and sort of ask what is the probability that this person develops or acquires HIV in their lifetime. And I think these numbers really are the most stark to me. So if you're a man who has sex with men and you're in the Black or African American demographic, there's a 1 in 3 chance of acquiring HIV over a lifetime. And you can see how that disparity ranges from white men who have sex with men, 1 in 15, drastically different, with Hispanic and Latino as sort of the second highest incidence population. Thinking about the geography of HIV in the United States, about half of new diagnoses are in the South. We don't have the data up there, but the South definitely makes up less than half of the population of the United States. So that's sort of a disproportionate share of HIV infections. Digging in a little bit closer, if we look at what metropolitan areas have the highest incidence of HIV, our region right here, Miami, Fort Lauderdale, has had the highest incidence of any metropolitan area for many years running. And you can see in the top 12 major metropolitan areas, we have 3 in Florida. So we're really in the center of the HIV epidemic in the United States here in South Florida, unfortunately. And you can see out of those 12, only 2 of them are from outside of the South. So there's a county in California, Bakersfield, and then Las Vegas, but the rest are cities in the South. Zooming in even closer, we can look at HIV in Fort Lauderdale and Broward County. So in the county here, we know that there's about 21,000 people living with HIV. So we're switching to prevalence here, whereas previously we were looking at new infections. You can actually look based on zip code even. And so in Wilton Manor's zip code, which is 33305, that's sort of the highest prevalence in the county. The rate is essentially 9.5%. So 1 in 10 people living in Wilton Manors are living with HIV, which is just really astronomically high compared to other parts of the country. And, I think often, unfortunately, not given as much attention are women with HIV, who continue to make up about a quarter of new diagnoses and prevalence of people living with HIV as well. I'm going to skip this slide for time, but it just sort of highlights again that there's sort of a disparity in the populations having HIV in Fort Lauderdale that sort of carries on from other parts of the country. One point here I just wanted to highlight, which was this little box, which is just looking at how we compare between different kind of gender and race ethnicity groups. So the disparity in HIV among women, comparing Black to white women, is actually the highest disparity of any demographic group. So again, just thinking about why are these groups so disproportionately affected, and what are sort of our tailored interventions for preventing HIV in those populations. So to just sort of make it explicit, so for Black males in Florida, the rate of HIV between Black and white males is 6 versus 1, and for females it's 11 versus 1. So a lot of the disparities in HIV are hypothesized to sort of stem from what we call the social determinants of health. So either the factors outside of someone's biology that impact their health status. You can see that in Broward County, we have a particularly high rate of unstable housing, high but relatively equal rate of poverty and food insecurity compared to other parts of the country. And all of these factors are really shown to be strongly associated with acquiring HIV and having sort of negative outcomes when people already have HIV. This just shows, again, that there's the disparities we see in HIV are also present in some of these social determinants of health. So Black individuals in Broward County much more likely to be experiencing food insecurity than Hispanic and white individuals. So until now, I've been talking about people who become infected with HIV. Thinking about the other side of that coin are the people who are transmitting HIV. And I think that's also a really important piece of this to think about, because as we'll talk about later on, treatment as prevention is one of our most effective tools for preventing HIV. So people generally fall into 4 categories who are transmitting HIV to others. The smallest is people who recently acquired HIV. So that's people considered to have acute HIV infection. About 38% are people who have HIV but don't know about their infection. And so those are people who we really need to focus on scaling up of testing. There's another big group, 43%, who know they have HIV but are not getting treatment. And so those are people we really need to work on finding ways to provide treatment in a low barrier, culturally concordant manner. And then finally, we have about 20% of people who are in care, seeing a doctor, but for whatever reason are not virologically suppressed. And in those cases, there's a lot of work to do, but a lot of it has to do with managing some of the social barriers to taking medication every day, sometimes managing side effects, comorbidities, concomitant substance use disorders, and mental health conditions. And then one group you don't see on here are people who are in care and virologically suppressed. And that's because, fortunately, those people cannot transmit HIV. And so we'll talk about that a little bit in future slides. Okay, so HIV testing. So these are taken from the CDC guidelines. A lot of this is just kind of like nearly copy pasted from CDC guidelines. So I'm not going to read it all out to you. But I think the main points here are every person in America between 13 and 64 should have at least one HIV test in their lifetime. And then, beyond that one test, they're sort of risk-based increase in the interval of testing. So people who are at higher risk, which is, you could consider anyone having sexual exposures, especially, as risk increases, you would want to test more frequently. If people are being tested for other STIs, that's sort of a sign that they could be at risk for HIV. And so HIV is generally considered part of standard routine STI screening. We also will talk a little bit about finding people with symptoms of HIV and how to identify those folks as well. So we have this kind of somewhat new approach to HIV testing. And the idea is that whereas previously, I think the mentality was, you test a patient, if it's negative, you give them a high five and say, see you later, come back next year. This sort of promotes the idea that regardless of the outcome of the test, it should lead to some action as a healthcare provider. And so we'll go down the right side first, which is basically looking at if you're positive for HIV. So that's simple. So if you're positive, we want to get you onto treatment. We want to get you retained in care. We want to get your viral load suppressed because that means you are undetectable, which equals untransmittable. And so that's what the U equals there. On the other hand, if your test is negative, instead of just giving someone a high five and saying, see you later, then the next step is to sort of say, that's great that you're negative. Now, what can we do to help keep you negative? And that's where a lot of what we talk about coming up comes into play. So taking a good sexual history, learning how to talk about PrEP as an option for people, learning how to get people onto PrEP, and also engaging in other sort of health behaviors to reduce risk of HIV infection. Our gold standard test right now for HIV is called the 4th generation antigen antibody test. This test, usually the downside is you don't get it back the same day. But otherwise, this is sort of considered the gold standard. It still can take, between 2 to sometimes 12 weeks to turn positive after infection. But it's the window sort of getting shorter and shorter over time. Rapid tests are something that there's a lot of interest in and I think have a really important role, especially in starting people on PrEP, as well as just increasing the number of people being tested. Like I'm assuming at this health fair, I think they're probably going to be doing rapid testing. The benefits are that you get results right away. You can start making actions right away as far as treating people or starting them on prevention for HIV. The downside is the test is a little bit less sensitive and less accurate, less sensitive and less specific. So can take longer to turn positive. And sometimes positives are more likely to be false positives. So the bottom line is both of these tests actually can miss really recent or acute infection. And so in those cases, actually, we'll talk about that later on. We're going to switch gears right now to cultural humility. So this is a really important topic for how we deliver PrEP to people. But to start things off, so cultural competency, that's sort of like, think of that as the bedrock principles. So these are things that you can kind of like learn from a lecture or a textbook, let's say. This is as a physician or provider, knowing about, facts about different people's cultures, about how certain cultures are referred to certain things or, different rituals and values. This involves sort of building your own self-awareness. But generally, it's sort of based in concrete facts. So, you could read a textbook about whatever, we have a lot of Haitian Americans in Miami. And so, we sort of learn in medical school, when I was in medical school in South Florida, just sort of about cultural health practices in the Haitian American population. Cultural humility is sort of one step beyond that. So that's sort of this ongoing long-term process of critical self-reflection. It sort of focuses on ongoing learning, being vulnerable, this kind of lifelong commitment to bettering yourself and working on your empathy and connecting with patient populations who might be very different than yourself. The theory here is that by improving cultural humility, we can kind of reduce a lot of the minority stress that individuals experience in the healthcare environment. And, there's plenty of research sort of explaining how people go to their doctor asks them about their sexual practice in a way that they find offensive, and then, they never want to go back to that doctor again. Fortunately, in a big metro area, we have more options, but a lot of folks don't have many options. Ideally, cultural building cultural humility can help reduce some of these cultural misunderstandings, but it cannot eliminate them. And that's actually more of a feature than a bug, I would say, because again, it's really this process of chronic long-term growth and change. And so you're going to make mistakes. And the idea is, how do I learn from my mistakes and become better and adjust over time? Our culture is going to change over time. I'm sure, words we use in this presentation today will seem obsolete 20 years from now. Just like when I read old HIV textbooks, my head like explodes with some of the things that are said in there. And so again, it's just sort of coming to things with a sensitive and open-minded approach, non-judgmentally. And bringing this back to HIV, so we know that people either living with HIV or those who are at risk typically have multiple oppressed and stigmatized identities. And so I mentioned before, we have being young is a risk factor for HIV, being from a minoritized population like Black or Hispanic, being from a sexual minority group like LGBTQ, whatever, populations, anything that's not sort of cisgender, heterosexual. And when those things start to compound, someone has multiple identities, the difficulty in accessing and obtaining care increases. Okay, this is, again, I think kind of highlighting what I mentioned. Again, really focusing on if people don't feel comfortable talking about their sexual, substance use, mental health with providers, the care is really going to be subpar. And so our goal is to really improve the experience for patients. This guide kind of gives a little bit some steps to building trust with patients. I won't go through all of it, but it's just sort of, again, highlighting this increasing awareness, trying to learn. I think one thing not mentioned on here is trying to think of ways to get feedback in your practice, whether that's feedback from patients or from, I always ask when I have a medical student with me for feedback, like, did I say anything offensive to any of the patients we saw today? And just sort of building that culture of giving feedback non-judgmentally within your medical practice. This is a little bit of a reference for you, so I won't go through in great detail, but this is just sort of a guide for some of the terms that are important to know in working with sexual minority individuals. So just sort of knowing the difference between sex assigned at birth, gender identity, gender expression, and sexual orientation, which you can see some of the terms there. And if there's any specific questions about it, we can talk about them after. Okay, and then this is also a little bit of a mnemonic for helping doctors or nurse practitioners and physician assistants help in taking a sexual history. And actually, I guess our health department friends as well, I think, have to take sexual histories from people they interview. So the 5 Ps are kind of, I would think of this a little bit as a checklist to make sure you're not missing anything. So you want to know about the partners that people are having, the number, the demographic of those partners, the specific sexual practices that are happening, STI treatment and history, and then also pregnancy plans if someone is able to become pregnant. And I think I put that little bubble on the side there, which is just to say, I think a lot of our training in medicine for taking a sexual history is really based on like, what are all the things that are going to hurt you or kill you in what you are doing with sex. And we know that from kind of empirical research that when we counsel patients with a positive message and a health promotion message, it's a lot more effective for getting people to engage in care and to make behavior changes. So what does that look like? So instead of, someone coming into my clinic and I just start asking them, have you ever had syphilis? Have you ever had condomless sex? How many partners are you having? All of this list of things that, in aggregate can make people feel attacked. I start off by sort of asking, are you sexually active? What are some things you wish were better about your sex life? What are some things we could do to improve your sexual function, your activity, your comfort, your sense of self when you're having sex. So sort of promoting sex as something positive and something we as healthcare providers can help you to improve rather than just something that we're going to, prevent you from dying from it or getting some horrible condition. All right, so now we're moving on to the meat of the presentation, which is pre-exposure prophylaxis. So taking a step back before we get to PrEP, so the big picture of HIV prevention from kind of the biomedical model, at least, in 2024 mostly includes the things you see listed here. So treatment as prevention, I mentioned a little bit. So again, that's the idea that if we can get people with HIV on treatment and undetectable, they cannot spread the virus to other people. And that's the U equals U mantra. That's sort of something that's targeted at people with HIV. We're focusing today a little bit more on people who don't yet have HIV. So condoms are definitely something that has some efficacy. It's not as good as PrEP, as we'll see in a little bit of time, but certainly helps in preventing other STIs that PrEP does not prevent. Behavior modification. So that really used to be like the cornerstone of HIV prevention before PrEP, which was in 2012. It became FDA approved. So that was kind of the era, when I was in high school, and it was just like, don't ever have sex with anyone or you're going to die. And that was kind of like the counseling. There's sort of a little bit more sex positive approaches to that, but basically it was sort of like doing what you can to avoid HIV or avoid exposure to HIV. So reducing number of partners, making sure your partner gets tested, using condoms as an adjunct, having sex in non-penetrative ways, all of that stuff. Then when PrEP came out, and I think continues to sort of be a liberating force in sexual health and wellness for people. So it sort of said that you can take this pill or get this shot, and actually you don't have to make any of these weird behavior modifications. You can still do it, still reduces your risk, but that really this pill does most of the work. Post-exposure prophylaxis is the idea of taking an antiviral after someone has been exposed or potentially exposed to HIV. We know that sexually transmitted infections are a major risk factor for HIV transmission. So someone who has, let's say, syphilis and HIV and has sex with someone who's negative for both, the HIV is more likely to transmit if that person has syphilis or has a second STI. And then something we don't really talk about as much in the United States, but in Africa is, I think, a bigger piece of HIV prevention is that male circumcision has some benefits in reducing the rate of transmission, obviously only among persons who have penises and foreskins. Okay, so PrEP effectiveness. So PrEP, when used, pretty much all of the PrEP agents, when used, if you follow the label, take it every single day, do it exactly as prescribed, nearly 100% effective in preventing HIV. And, that's sort of, even in the absence of condoms, theoretically, it still works just the same. So in people who inject drugs, it hasn't been studied as much. There's actually only one major randomized trial, and that showed slightly less efficacy. But again, I think that was sort of limited by the adherence to the medication. As people are less adherent to their PrEP, so let's say they miss a couple of doses a week or they miss all of their doses per week, the protection kind of decreases in a stepwise based on how many doses people are missing. And, unfortunately, PrEP does not prevent other STIs, so only prevents HIV. I think I would argue HIV is the one that, lasts forever and can kill you, whereas gonorrhea, chlamydia, syphilis, definitely bad. We definitely want to treat them, but maybe don't have as much long-term problems. Okay, so this is a key point here, which is just to show that the disparities we see in HIV infection really sort of unfortunately carry on into the PrEP world. So Black individuals, they account for nearly 40% of new diagnoses, but only 14% of the people who are taking PrEP in the United States. So that's considered sort of the PrEP gap. The idea is we our goal would be that it'd be sort of proportionate. So the people who are most likely to get HIV should also be the most likely to be taking PrEP. You can see in Florida, we are actually doing a little bit better in that the PrEP gap is slightly smaller in the Black individuals. One thing that's a little bit, misleading about this is that PrEP is not like a zero-sum game. So there's enough PrEP for everyone. So theoretically, we could have everyone at risk for HIV on PrEP and still have plenty of PrEP left over. So it's not like, if one Black individual takes PrEP, it's taking away from white individual. All right, so who should be considered for PrEP? This is a really long list. The main point is anyone who requests it should be offered PrEP, assuming there's no medical contraindication. So for healthcare providers out there, we'll go through the medical contraindications, but that should really be the backstop. But anything that is safe based on your medical opinion, we should be not asking too many questions if someone is a little bit shy or doesn't want to disclose their risk factors. But most of the risk factors or most of the conditions to consider for PrEP are kind of obvious. So if someone has had an STI, HIV is an STI, therefore they're probably someone who has had risk of getting HIV in the past. If someone who's needed non-occupational HIV post-exposure prophylaxis. So let's say someone, has condomless sex with an unknown partner. They're not sure of their HIV status. They can go to ER and take a month of antivirals to prevent acquisition after the exposure. That would probably be a good person to offer PrEP to, in that they're likely or may have future exposures like that. I'm going to not read all of these, but injection drug use is a major one. People with history of incarceration is a major one, just because there's a lot of HIV within prisons and actually a lot of transmission even within prisons. And again, anyone who asks for it. The context matters point, that's to sort of highlight the fact that HIV risk depends on a lot more than just behaviors. It also depends a lot on the geography, like we've talked about, and the community and sexual networks that people are involved with. So, for instance, in Fort Lauderdale or South Florida, where we have the highest rate of new HIV in the country, having condomless sex with one individual has a much different risk than having condomless sex with one individual in Wyoming, where there's 25 people with HIV. And so that's sort of, basically you can't go purely based on behavior. You have to look at people's context and their community. All right, so now we're going to dive into the specifics of the agents for PrEP. There are 3 FDA approved medications currently. 2 of them are pills and 1 of them is an injection. All of them are antivirals that are used to treat HIV. And one of the key points to remember is that to treat HIV, usually patients are on a regimen that includes 2 or 3 powerful medications. And that's kind of what's needed to beat down the virus and help people's immune system recover. To actually prevent the virus from getting into the body and setting up shop, we can use fewer medications of lower intensity. And so something that I think sometimes people get confused by is that a lot of the meds are used both for treatment and for prevention, but usually the full package is different. So the full package of treatment for HIV would include one of these 2 tablets plus a 3rd medication. But to prevent HIV, we only need one of these 2 tablets. So these are pretty much the same. Truvada, which is tenofovir disoproxil fumarate with emtricitabine, or Descovy, which is tenofovir alafenamide with emtricitabine. So those are, again, 2 HIV treatments that we've had for many, many years, very effective for treating HIV and have a lot of long-term data of safety and efficacy. They have, the one on the tenofovir alafenamide is quote unquote newer, I would just say that it has slightly different side effects. And so this is something where you're really going to have to tailor it to your individual patient. So just kind of like the top line differences, tenofovir disoproxil fumarate with FTC, that one, the big issue is that you have to have a better creatinine clearance. And there's some minor, although it's very questionable, the clinical significance of the effects on kidney and bone density over time. But people who are at risk for kidney disease or people who are at risk for osteoporosis, you might want to avoid that one. Usually causes a little bit of weight loss. And so a lot of times people who have some weight that they want to lose might choose that one. The tenofovir alafenamide can be used in people with more kidney dysfunction. That one has kind of the opposite metabolic effects, so can kind of worsen some of the lipid profile and also can lead to a little bit of weight gain. There's also differences in which populations they're FDA approved for. So you can see them listed there. Truvada or tenofovir disoproxil fumarate emtricitabine, that's the one, if you don't remember anything, that can be used in all studied populations. And then the one on the other side, tenofovir alafenamide or Descovy, that one so far has only been studied for men who have sex with men or transgender women via sexual exposure. The tenofovir disoproxil fumarate or Truvada, that one has this one really nice option, which is not FDA approved. I think I mentioned before, but this is called sex-driven or on-demand or event-driven PrEP, or sometimes people just call it 2-1-1 PrEP. The idea being that, some people don't want to take a pill every single day if they're going to have sex, once a month or something like that. And so the idea here is that you can take 2 pills before sexual activity and then 1 pill the next day. And then 1 pill the day after. So it's basically like for 2 days after the sexual exposure. And that's only for men who have sex with men and transgender women. Okay, the injectable PrEP, which is called cabotegravir or Apretude. This is studied for all people with sexual exposure to HIV, has not yet been studied in people who inject drugs, but can be used in men, women, transgender women. And this is given once a month at the beginning and then every 2 months. So positives of this, obviously, is you don't have to take a pill every day. You do have to come in every 2 months and get a big syringe stuck into your gluteal muscle, which can be bothersome for some people. And then on the right, my left, that little graph just shows the long tail of the medication. So it has such a long half-life that we're still trying to figure out exactly when it leaves your body. And so in studies that were done after stopping it, people have detectable levels for years afterwards, like up to 5 years after their last dose. And so that's good to keep in mind. This is something that we don't have a lot of long-term data on. We don't know if it's safe in pregnancy. And so if you have a young, fertile female who might want to get pregnant in the near future, who wants to avoid having a, unknown medication in their body during their pregnancy, this might be something to avoid. Okay, this is a table kind of summarizing that data, which I will skip for now because I think our time is running low. I'll just mention briefly, this is not yet FDA approved, but we have 2 studies that came out in the last couple of months that are looking at a once every 6-month injection to prevent HIV. The first study here, Purpose 1, looked at women or cisgender women and showed 0 HIV infections in those who took this twice yearly subcutaneous injection, was more effective than both types of oral PrEP that were studied. And then there was a second study that we only have a press release on so far, but also showed really extremely high efficacy, even compared to oral PrEP. Contraindications to PrEP. So most important contraindication is having HIV. So really important that we test for HIV and that we screen for symptoms of recently acquired HIV. We'll talk in the next slide, I think, about some signs of recent HIV infection. Certain medications have certain, weight and kidney clearance differences that I won't go into detail. But the last point there is the key one, which is that there is a PrEP regimen for anyone, basically, based on these often used categories. So we have one that's safe for pregnant and breastfeeding people. We have one that's considered effective for injection drug use, and we have one that can be used in people who have chronic hepatitis B. So this is just a slide highlighting some of the symptoms of acute HIV infection. So if someone comes in and they want to start PrEP, it's good just to do this kind of review of systems of, have you had any sore throat? Have you had any swollen glands? Have you had any cough or rash? And then this is when a physical exam is helpful, although I don't think it's required. There's lots of people who are starting PrEP just by telemedicine. In the case that you suspect that there could be acute HIV infection, you would want to check an HIV viral load. Okay, and then this I think I'm going to skip. And I'll just mention briefly same-day PrEP initiation. So I think this kind of applies as well. We'll talk later about same-day ART initiation. But the idea is that both for PrEP and for treating HIV, we want to get people into care as fast as possible. There's a really, really huge drop-off when you sort of say, okay, come into clinic, we'll do your labs, and then come back next week, review your labs, and write a prescription. And so we're trying to flip that on its head and say, let me draw your labs and give you the prescription at the same time. And then in the very, very unlikely chance that there's something in the lab saying you can't take this medicine, usually there's really no harm in someone taking a week of PrEP or a week of ART when they have some kidney issue or some other contraindication. Okay, so the screening, this is sort of follow-up testing for people who are on PrEP, which I won't go through, but we'll just leave as a reference. The main thing to realize here for those who are have less experience with the injectable form of PrEP. So that one, the recommendation for HIV testing is to check an HIV RNA with each of the injections. The difference is that one is like so powerful in treating HIV, even if someone acquires HIV while getting that injection called cabotegravir, that it can cause some delays in the normal HIV antibody test turning positive. So the HIV RNA is the best way to diagnose HIV in those people. Okay, so this, I kind of mentioned this a little bit, but the idea of applying a harm reduction lens to HIV PrEP. So this is really just sort of being patient-centered and focusing on getting the care to people who need it versus kind of having a lot of preconceived or dogmatic ideas about how healthcare should be delivered. So we like to provide PrEP in the lowest barrier possible. So, ask the fewest questions, make people jump through the fewest number of hoops to get PrEP. There's guideline directed lab monitoring, but if someone can't afford to have their triple site gonorrhea chlamydia testing, but still wants to be on PrEP, I think some traditionalists would say, no, you have to get the whole package. You can't just get the HIV testing. I'm not prescribing it. But this is sort of where we try to meet people where they are and help them get the treatment sort of on their own terms. This is also important for when we're helping people choose a PrEP regimen, which, unfortunately is often dictated by health insurance. But in the event that they do have some options, we can ask them, are you more averse to taking pills every day or more averse to getting injections? Do you want to take something on demand or do you want to take something daily? And all of those things can be used to kind of determine the best agent for each person. Helping patients pay, I'm just going to leave this as a reference, but this is just a guide to sort of some programs that can help support PrEP. Adjuncts to PrEP. So PrEP, very effective for preventing HIV. We should take advantage of the fact that we have someone in our clinic or in our healthcare environment, and there's all this other great stuff that we can do to improve their health. So while they're there for PrEP, we want to screen them and treat them for HIV. We want to, for other STIs, we want to offer them preventive therapy for STIs called doxypep, which I'll talk about in a moment. make sure they have their age-appropriate immunizations. If there's someone who can get pregnant, talk about contraception. And then we see a lot of, substance use and mental health conditions in our population on PrEP. And so really trying to provide a one-stop shop and like holistic care and not just focus so specifically on this one virus, which it's great to avoid, but there's a lot more to health than just not getting HIV. Okay, so this is just to show that STI rates are going up, bad direction. And again, I mentioned before that STI is sort of associated with HIV infection. So doxy-PEP, so this is something that, you can have a whole hour presentation on it, but just to be aware that there is a new CDC interim recommendation for this, which is basically a post-exposure treatment with doxycycline to prevent STIs. So this is only really proven effective for men who have sex with men or transgender women. But if they have a condomless sexual encounter with someone, they can take 2 tablets of doxycycline, ideally within a day, but within 3 days is acceptable. And it's quite effective in preventing gonorrhea, chlamydia, and syphilis transmission. So, whether it's post-exposure, pre-exposure, but the idea is that, the bacteria is on the person's body, and if you give them a dose of this medication, it kind of beats it away so that they don't get the infection. All right, and then our last topic, which I'll whiz through here, is the HIV HIV treatment. So what do you do if your HIV test is reactive? So first off is, doing a self-assessment of your comfort with this situation. And, it's always good for us to push our boundaries as physicians, try to learn something new, try to acquire new skills. But if you absolutely do not feel qualified to start someone on HIV treatment, then the most important thing is sort of knowing where you're going to refer that person and how you're going to provide a warm handoff to that provider to treat HIV. I think most health departments, at least in Miami-Dade, we have sort of same day or rapid start programs that people can be referred to. So the reason we want to start right away is because we want to get the viral load undetectable as fast as possible, both for that person's health as well as for the public health. Again, doing the treatment as prevention. So what can you start? So these are the 3 regimens that you can start before having any testing done. So again, similar to the same day PrEP start, we're going to draw the labs and hand the prescription at the same time. And then, we can deal with any problems in the labs afterwards as they trickle in. So the 3 options are bictegravir, tenofovir, emtricitabine, that's also known as Biktarvy, dolutegravir, which is also known as Tivicay, plus tenofovir, plus lamivudine or emtricitabine, and then boosted darunavir with tenofovir plus lamivudine or emtricitabine. And the first 2 regimens are not to be used in people with previous exposure to cabotegravir containing PrEP. So if someone is on PrEP and acquires HIV, that's a little bit more of a nuanced discussion. This would be really focusing on people who have not been on PrEP in the recent past. Okay, so this is the kind of list of good baseline testing to have done. So this is what you want to draw before the person leaves your clinic with their new diagnosis. I highlighted 2 things there in bold, the HIV RNA and the genotype test. So those are the 2 that you really need to get done before the person starts their medication or within a day or 2 of them starting it. The HIV RNA, we use that as a way to confirm infection. So I see a lot of people with false positive HIV tests or presumed false positive, but they got started on treatment and never got a viral load. And then we check their viral load a month later and it's undetectable. And you don't really know, is it undetectable because they don't have HIV or because they've been on ART for a month already? Same thing for the genotype. So the genotype can only be done while there's virus in the blood. And then I think I talked already a little bit about post-exposure prophylaxis, but the main point here is just that if someone has an exposure to HIV or potential exposure to HIV, that they should qualify for taking a month of a full antiretroviral regimen for 28 days. That should be started within 72 hours. And the main point here is that if that person had sort of a sexual encounter as their risk factor, especially if it was like, consensual sexual encounter, that would be a very good person to be on PrEP after they finish their NPEP. So key takeaways are that HIV can be prevented with PrEP, which reduces the risk of HIV from sexual contact by 99% when taken as prescribed. It's indicated to prevent HIV via sexual transmission in adolescents and adults. It can be considered for all sexually active adults and adolescents. Only contraindications to PrEP are current HIV infection or weight less than 35 kilograms. And recent STI or requests for tests for STI or HIV should all trigger a discussion for PrEP. PrEP does not prescribe equitably. Black individuals face the greatest gap between HIV diagnoses and the use of PrEP. And cultural humility leads to greater self-awareness, reduced implicit biases, and increased sensitivity to power dynamics and cross-cultural interactions, but it cannot eliminate all cultural misunderstandings. Everyone with HIV should be treated regardless of CD4 count or viral load. Several regimens can be used even before baseline testing results are available, including the single tablet regimen of bictegravir, tenofovir, and emtricitabine. Okay, so now we are going to move on to the post-activity polling, which we will see how much of that information you have absorbed into over the last 45 minutes. And these questions will look very familiar, so I'll read them again. Question number 1, which of the following populations has the highest HIV rates and is least likely to receive a PrEP prescription? A, Asian, B, Black, C, Hispanic, D, white. Yeah, so again, I think we've mentioned it many times over the talk, but disparity in both HIV infection as well as PrEP implementation in the Black population, Hispanic population, sort of second to that. And again, we don't want to take away PrEP from anyone. It's great that lots of people are on PrEP, but we really just need to find a way to juice it up, especially in these certain populations. Okay, number 2. Okay, cultural humility is theorized to lead to all of the following except greater self-awareness, reduced implicit biases, increased sensitivity to power dynamics, elimination of all cultural misunderstandings. The correct answer to this one is D. If you're a good multiple choice test taker, avoid answers that say all in them because nothing is 100%. But yeah, I had mentioned earlier that increasing your cultural humility, you won't be 100% of the time successful. And again, that's sort of one of the important aspects of it is to make mistakes and learn from your mistakes and learn how to be better. Okay, which of the following is a contraindication to PrEP? Current injection drug use, pregnancy, reactive HIV test, hepatitis B, or use of feminizing hormones? Okay, so I'm going to say the answer, which is C, reactive HIV test. So this one's a little tricky just because the other ones can be relative contraindications and, you might think twice about what agent you're using for PrEP, but the only one that is absolute is HIV being positive, because what do we want to do in that case? We want to treat their HIV, not give them PrEP. Okay, and then number 4, which regimen can be offered to people with no previous use of PrEP who are newly diagnosed with HIV, even before results of baseline testing are available? A, abacavir, lamivudine, dolutegravir. B, bictegravir, taf, FTC. C, lamivudine, dolutegravir. And D, taf, emtricitabine, rilpivirine. Okay, and I think the correct answer here is bictegravir, taf, FTC. So that is one of the ones that can be used without any previous testing. I think someone answered the C, lamivudine, dolutegravir. So that one is somewhat incorrect. It's not as correct, I would say, as bictegravir. That one, there's some sort of like stipulations based on what the viral load is and whether or not they have some baseline resistance testing performed. I think there are some studies using that as like a rapid start agent, but stopping it if they have a contraindication. But for people in the community, you should be focusing on the three that were mentioned. Okay, so that is all of the presentation. I think we're moving on to the questions section. We will now move on to the Q&A. Okay, so questions. Should I answer the learner questions from here? Okay, so the first question I see here, it says, to my knowledge, HIV was identified in white homosexual men. I often wonder how HIV came to be more prevalent in the Black population. That's a really good question. I don't have a clear answer for it. I think, the fact is that it might have started or sort of blossomed in this population, especially in New York and San Francisco, where there's a lot of, close sexual networks among white gay men back in the early 80s. But, people have sex outside of their sexual network all the time. And so obviously it was going to spread to other populations. We know that there's lots of heterosexual men and women with HIV, people who inject drugs with HIV. I think a lot of where we stand right now with who has HIV is really related to those social determinants of health primarily. So, it's hypothesized that in the South, we have like the lowest access to healthcare. We have a lot of people who have kind of stigmatizing views towards sex in general, and especially, sex between men and women, or sorry, LGBT communities. And so I think all those things sort of build up to this disparity that we're seeing. Okay, let's see. I have one question here that says, if someone was previously diagnosed with HIV and had a lapse in treatment, but is now ready to re-engage in treatment, how does that affect the choice of treatment? So that's a good question. To be honest, that's a lot more likely of a situation for you to see than someone who's a new diagnosis, which, fortunately is a lot more rare. It's a little bit of a nuanced answer. You kind of want to ask them about what was the circumstances of them stopping treatment. In general, let's say the most simple case is someone who, was on treatment, they were undetectable, and they lost their insurance changed, and, they lost their doctor or whatever. In those cases, usually just restarting what they were on before is acceptable. At the same time, if it's someone who you feel like could follow up with a provider, it's also okay just to wait and refer them to a provider. But again, the harm of starting someone on like their old regimen is very negligible unless, they had some life-threatening allergy. I think the paradigm, which is like probably still entrenched from the 90s of, you have to be 100% adherent 100% of the time with your HIV medicine. And if you miss a single pill, you'll develop resistance and fail forever, is really kind of the opposite in that, there's a lot of wiggle room with treatment. They're extremely safe. And in almost every case, you should just err on the side of getting someone on treatment, even if it might not be their exact ideal or forever treatment. I'd like to give a huge thanks to DKB Med and Sunshine Cathedral for putting this all together and letting me give this wonderful presentation to you. So thanks all for coming.
Thank you, Dr. Sirota, and thank you for watching. As Dr. Sirota mentioned, we'll be back in Fort Lauderdale for a companion community event at Sunshine Cathedral on Saturday, November 2nd, 2024. We're partnering with Holy Cross Health to provide free testing for HIV, hepatitis C, diabetes, and hypertension. If you know members of the community that could benefit from that, please let them know. We'll also be coming back in the winter, early spring of 2025 for another health fair. For more information, please go to sunshinecathedral.org. To claim CME credit, please click the Claim Credit button on your console. Thanks for watching and take care.